My name is Carol. I'm the newest nurse practitioner working with Dr. Churchill and Ann. I started here in September of 2014, I think so. Been here for a little bit. I love teaching. I'm married to a farmer. It is very hot and dry out, so my farmer is starting to irrigate in June, so he's not happy about that. And I own too many chickens. That's a fun fact. There will be a quiz at the end. Okay, so first of all, why are we talking about this? You know, when we talk about do no harm, how does that apply to prescription opioids? And I think that the thing we have to remind people of sometimes is that these medications really can do harm. You know, when we look at issues with addiction or being abused by others, meds being stolen, crime, things like that. So I try to reiterate that these aren't just like nice M&Ms. These are actually very powerful, potent medications that have to be used appropriately. And in my practice, I really try and focus on not just do no harm, I want to do patients good. It is not good for patients to be hooked on medications and things like that. So I am going to focus on hydrocodone. Obviously, there are a lot of prescription opioids out there. Hydrocodone is the most common one that we use here. And actually, in our team, we don't really go above the highest dose of hydrocodone that we can use. Obviously, that's a preference for us, but that's the one that we feel works best for arthritis if it's needed, and we don't go above that. We refer that one out. So hydrocodone is now a Schedule II drug. That changed in 2014. Drugs are scheduled by the DEA from 1 through 5. 1 is the most restricted. So it's the second most restricted category that we have. So I think it was a Schedule III. Don't quote me on that, I could be wrong. Okay, national statistics that we see. As you can see on here, these are very commonly used medications. And any recent use is associated with an increase for overdose events. That is kind of a no-brainer. There's a dose-dependent association with risk for overdose death. That just means the higher the dose, the higher the risk of having bad outcomes from it. Hi there. Oh no, you're fine, come on in. Oh shoot. Do you need some water or something? I know it's kind of hot out there. Yeah, help yourself. No, you're fine. I can just go on, barely skip a beat. Again, higher doses associated with increased risk of overdoses, road trauma, and these are the big risk factors that we'll talk about. Most fatal overdoses happen with more than one person prescribing the same medication and that higher dose that I talked about. Now, just in case you think that this is a national problem, not something that happens in Nebraska, you are very wrong. And this is the most recent data that I could find from Nebraska Vital Records, but 84 drug overdose fatalities in those 6 months. 81% were unintentional, so they ruled out who had tried to use those to commit suicide. Those are actually a little scarier to me. I think that means that these people are accidentally being hurt by these medications. Again, a need for greater education. And those are just some of the demographics associated with it.
Is this only hydrocodone?
No, that is all prescription narcotics. Yep. I'm going to focus on hydrocodone when I talk about the prescribing, but yeah, the stats apply to all of those. Just for the sake of limiting the scope of this talk, so I don't talk all night, things I'm not going to talk about, the long-acting opioids, you know, the OxyContin, things like that, fentanyl, things like that. Those are above my pay grade. If a patient needs to be on those, we refer those to a pain specialist. Those require an even higher level of vigilance with watching them. So for the sake of it tonight, I'm not going to talk about that. Treatment for substance abuse. If we identify that someone is misusing these medications and we need to start a process to get them off of them, again, I would refer that out. That's another very specialized area of medicine. And then finally, illegal substances. I will not be discussing the use of marijuana in pain management. It's a question I get all the time. It's illegal in Nebraska, period. So even if it weren't illegal in Nebraska, I would still refer it out because it would require that specialized pain focus, whereas I, have to treat a lot of different kinds of arthritis. So anyway, any questions so far on that? Okay, so just a little bit of background about opioids. We're going to go through how they work in the body, of course, benefits, side effects, and then we're going to talk about addiction versus tolerance, because that's something that patients ask me about a lot, and so I think that it's worth mentioning. There you go. Okay, background on opioids. They're naturally occurring substances. Now, take that with a grain of salt. One of my nurses, her favorite quote is, just because something is natural, she says, snake venom is natural. That doesn't mean that it won't kill you. And we deal with this a lot with herbal medications and things like that. Just because it says natural on it doesn't mean that it can't kill you. Opium derived from the seeds of the opium poppy. We've all seen that scene in Wizard of Oz where they're going through the poppy field. Of course, most of ours are synthetically created nowadays. It's obviously been around for a while. And when we talk about opioid, we kind of use opioid and narcotics interchangeably. Interestingly enough, narcotic is from the Greek word, I don't know the Greek word for it, derived from the Greek word for stupor. So I always think that's kind of funny related to these, narcolepsy, etc. So that's a little bit of the history of them. Click. Okay, here we go. Okay, so this is going to be really basic for how they work. So you take an opioid medication, whether you ingest it through your stomach or IV, what have you. It relieves pain by acting on opioid receptors in the body. It has the most effect at the mu receptors. So those are in the central nervous system, in the brain and spinal cord. And those are the same areas that control heart rate, breathing, bowel movements, euphoria, and also that's kind of where addiction happens. So hydrocodone works primarily at the mu receptors, like I said. There are other receptors, delta and kappa, things like that, but that is not something that we'll talk about. If you've ever heard of the medication that they can give to reverse the effect of narcotic medications, in the hospital we call that Narcan, naltrexone, or naloxone. I never know how to say it. That is a mu receptor antagonist, meaning it blocks things off of the receptors. So if someone had too much of an opioid drug that was activating the receptors too much, you give Narcan and it comes in and it knocks those off. So I saw the article on Prince in the news that Prince, he was taking fentanyl, which again, more hardcore than hydrocodone, had overdosed on fentanyl once, and they were able to give him Narcan and reverse the effects. Unfortunately, the second time, no one was there to give him Narcan to reverse the effects, and he passed away from it. So anyway, that's a very, very, very basic thing on how they work. So benefits. When we talk about benefits of an opioid medication, there's pretty much one. There's pretty much one reason that we would use it. It's to relieve pain. And a lot of when we do this is recovering from surgery. Obviously, post-surgical pain is something that can be very detrimental. We want to get patients out of bed. We want to get them moving. We want to have them deep breathe so we don't get pneumonia after surgery. There's a very standardized use of pain medicines after a knee replacement surgery or a hip surgery, of course. The expectation generally is that they'll be used for a short period of time. Typically, we don't want to be using these medications more often. And the research all says you can only continue to use them if they actually are working, if you're actually showing improvement. We're supposed to use them for a short period of time. If there's improvement, try and taper off of them and get to the lowest possible dose or get off of them entirely. If they're not working, get off of them right away because they're not working and they're dangerous. So anyway, one of the things that I use pain medications for, like in treating my osteoarthritis patients, is because if people are overweight, generally they have trouble exercising because of the pain in their knees. So I give them medications that can help them be more active without pain, hoping that they will exercise more and lose weight. And then we could stop the drugs, if that makes sense. Okay? So we talked about the benefits. Let's talk about the negatives, which are usually the side effects. All of these are, related to when we talked about the activation of those mu receptors in the central nervous system. I have a lot of patients that have nausea, abdominal pain with these. They cannot handle them. Constipation, that is a huge one. I am shocked when patients don't know that narcotic medications cause constipation. They should print that over the door of the hospital or something like that. So in the hospital, we manage it really aggressively, and I'm trying to do a better job of that in the clinic to really remind people, if you've never been constipated before, boy, you are going to be on these medications. So changes in blood pressure, respiratory depression. That's the one that we're going to come back to several times. Overactivation of the mu receptors shuts down your body's drive to breathe. Obviously, none of us think about breathing. That's how people die on this medicine. It shuts down their drive to breathe. And that's another one that I'm really shocked when patients don't know that, because I'm like, no, these are not pretty M&Ms. You cannot just take a bunch of them. Your body will stop breathing. So I will harp on that one a lot. The drowsiness, obviously see that one a lot, delayed reaction time. Obviously those two are things, reason why we don't want people driving on narcotic medications. And decrease in hormone levels as well. Talking about the addiction versus tolerance, I have a lot of patients that say, well, I don't want to be on that medicine because I don't want to be addicted to it. And after you've been on this medicine for a while, we have what we call tolerance. Your body gets used to having it in your system, okay? And just as due to prolonged exposure or use of a medication. And that's when sometimes they need higher doses to get the same effect. And that's why as providers we have to be really careful not to escalate that dose higher and higher. We have to look at other options for managing pain, because otherwise it gets dangerous. When your body has become dependent on a medication, it's used to having it around. If we stop it quickly, you don't feel well. That's withdrawal symptoms. And those usually go away after a few weeks, but that's why when we take people off of these, we really taper them down slowly. On the flip side of it, addiction. Addiction is considered a neurobiological disease. I always tell my patients, tolerance happens throughout the body. It gets used to it. Addiction happens up here. We consider those inappropriate behaviors, lying to get the drug, stealing money, stealing drugs to get more of the drug. Inappropriate behaviors related to that. So when I have people say, well, I don't want to use that, I don't want to get addicted, we have to have a talk about addiction versus tolerance because they're very different. Okay, so next we're going to move into the next section about prescribing these medications. Like I said, it changed to a Schedule II drug, which meant that it got a whole lot more restricted, a lot more work on our end, and unfortunately a lot of inconvenient stuff for patients too. And I can't do anything about that. That's how we have to do it. So, okay, so who can prescribe these medications? Or who does, I guess maybe would have been a more accurate slide title. Primary care provider, an arthritis specialist, which is us. I am a nurse practitioner. Nurse practitioners, PAs, and MDs and DOs all have prescribing authority, so we're allowed to prescribe these medications. Surgeons, obviously, when we talk about after surgery, and then pain specialists. And so, again, technically, could I prescribe OxyContin or something like that? Yes, I could. Do I have the training to where I'd want to do that? Absolutely not. So there's a wide range of who will prescribe what, and a lot of it is training, and a lot of it is education, and then some of it is preference as well. So prior to prescribing, this is something that we really need to start doing, is screening all patients for abuse potential, so kind of try and guess who's going to use this medication inappropriately, and then risk for adverse effects. Again, we're trying to keep people alive. I don't want people to be hurt by these pills. So who is at risk for side effects? Everyone is at risk for side effects, first of all. But people who are especially, we talked about reducing the respiratory drive, so automatically patients with breathing issues, asthma, sleep apnea, other things like that alter their breathing. When patients have pneumonia or are having trouble breathing, or if they're on oxygen at night, all of those things are considered risk factors. Doesn't mean that we don't use these medications, but we just have to be careful. Kidney or liver problems. Kidney and liver, they filter out the waste from the body. If they're not working properly, drug levels can build up in the body. Obviously, then you're getting the higher doses, more of the effect, more dangerous. Depression, mental health conditions. You have to be careful with these medications not to treat emotional pain with an opioid. Do they cause that euphoria? Do they make people feel better? Yes. But I use the comparison of if you have an infected wound and you put a Band-Aid on it, it looks better, we feel better about it, we don't mind the wound so much, but underneath it's not fixing the problem and it's getting ugly. So I always have to be really careful if my patients are using this medication to numb emotional problems. We got to get to the bottom of that, because you can never give a high enough dose to fix that, of course. Alcohol, substance abuse. It's just because you don't want to be using a couple of different medications when you're on these, that they can have an additive effect and worsen the side effects, or of course worsen the risk too. Pregnant women, that one is because any medication that a pregnant woman takes, her baby takes as well. And babies actually have to withdraw from these products, and that's a really terrible thing to watch. I've had to do it, and so, yeah, something that we should avoid. And the elderly, that one's purely because of the sedating effects and the fact that they are more likely to have some of these, more likely to have kidney or liver problems, more likely to have sleep apnea, and then also the risk of falls increases. I don't know the percentage, but it increases a lot. Okay, very, very dangerous. Those were like, use caution. This is like very dangerous to use these medications in combination with these. Antidepressants, muscle relaxants, benzodiazepines. And again, that's just because of the additive effect that you can stop breathing, you can fall, very sedating. Definitely shouldn't be driving on those. Dangerous to use other substances and driving and operating machinery. We have a lot of people that drive while taking opioids, and I think that most people have probably developed enough of a tolerance that that's not terribly bad, but it kind of is a scary idea when you think about how many people are on these drugs and driving. I also drive from Crete every day, which is kind of like a racetrack, so I obviously have to take a certain amount of risk in my life. So who's at risk for abusing the medications, like taking them inappropriately, developing addiction? And I almost felt bad putting this slide up because we still use these medications in these patients, but we just screen them for them. And there's a lot of patients that have these conditions that don't abuse the drugs. So it feels a little unfair to me to say that this is, but we have to try and predict what patients are going to have trouble with them. Again, safety. Okay, choosing medications, which drug is the best? Obviously, we have a lot of choices. I go to hydrocodone because that's the only opioid that I use, but it's also kind of my last resort. I try a lot of other things first. So what other options have been tried? The CDC talks about chronic pain, especially the fibromyalgia, things like that. Opioids are not appropriate for that. We use them for it a lot, but we got to get away from that because the studies show that it's not the most effective. So non-pharmacologic therapy, we're going to talk about that. Non-opioid pharmacologic therapy, we're going to talk about that. And if those other things don't happen, the opioids don't happen. And I'm having to start to have some tough conversations about, if you're not doing physical therapy, I'm not going to prescribe these drugs. If you're not exercising, I'm not going to prescribe these drugs. And I kind of skipped this one, sorry. We need to match the type of pain with the appropriate treatment. And this is something that I cannot educate patients on enough, that, like I was saying, chronic pain, opioids are not appropriate. So post-op, after surgery, short-acting opioids, the hydrocodone, the oxycodone, absolutely appropriate. They get you up, they get you moving, they help you breathe deeply so you don't get pneumonia, and then you hopefully wean off of them as your surgery scars heal and everything like that. Cancer pain, end of life, very, very tricky to treat pain-wise, and that requires a palliative care specialist. That's when the long-acting opioids and those things really come into play with cancer pain. As I said, mental illness, emotional distress, the things that are proven to work for that, counseling, antidepressants, cognitive behavioral therapy. The problem is that those things are a lot of work, whereas taking a pill is easy, and that's where we have to restructure our thinking to say, these pills aren't actually helping, we have to do the things that help. So chronic pain, again, physical therapy, NSAIDs, and neuropathic pain, that's like a fibromyalgia, diabetic neuropathy, something like that. Gabapentin and Lyrica are really the only medications that really attack that. And I have a lot of patients who tell me that they can't take NSAIDs because of their stomach or their heart or things like that. We have some fantastic products out there right now that are topical anti-inflammatories. Very, very safe. They are very little systemic absorption, so they don't upset the kidneys or the heart or the stomach the way the other ones do. I've been using them a lot. I prescribed them for my mom, actually, so. Okay, now back to the non-pharmacological treatment options. Physical therapy, obviously, ice, heat, nutrition and diet. I don't recommend it, but I don't tell them they have to do it, but I do have a lot of patients that cut out certain foods and they feel better. So that one's kind of a personalized one. Weight loss, I mean, it's a kind of a fact of nature that if you carry more weight, it's going to be harder on your knees and on your feet. Psychological therapy, that's the counseling, the cognitive behavioral therapy, counseling, support groups, things like that. Of course, that's addressing mental illness or, anxiety, depression, things like that. Okay, as I have said again and again, and I will say again and again, we have to teach patients, we have to do a better job of educating patients. We also have to do a better job of educating the public about these drugs. I mean, pharmacies are being robbed for these drugs, and so people really have to understand how serious that they are. So my goal is that all of my patients will understand the dangers and the side effects, how to take them appropriately, why they're taking them appropriately, and then I always tell them to tell their friends too. Okay, so behind the scenes at Arthritis Center of Nebraska, and I am going to speak to what the Dr. Churchill and the Renz and myself team is doing. Again, the other docs may do things a little bit differently, but this is how we're going to prescribe them, because this is what we've chosen to do. And part of this is dictated by the Schedule II, the fact that they're controlled substances. So it has to be a printed prescription. I can't e-prescribe it. I can't fax it. I have to actually print it out. I have to sign it, and the patient carries it with them. And one prescription is for 30 days. I can't write one for longer. They have to get 3 separate prescriptions, and they have to come back in and see me every 3 months. So if it's someone from Western Nebraska, I usually tell them, see if your primary care provider can do this. Otherwise, you have to come back and see me every 3 months. Again, dangerous medications, we have to watch them closely. I get that it's a pain. I get that there's a copay, and it's just I have to keep my patients safe too. If patients lose prescriptions, I can't replace them. I've had people, drop pills down the sink. I've had people tell me they dropped pills down the sink, and I don't think they did. So at some point, we just had to say, if you lose it, we can't replace it. Current opioid contract, I'm going to talk about that. That is a piece of paper signed by myself and the patient saying this is how it will be prescribed, this is what the patient's responsibilities are, this is what Carol's responsibilities are, this is how we are going to work together as a team to take this medication safely. And then they're going to have to consent to our monitoring program, which will involve urine drug tests, which we're kind of starting to roll out now. And one medication, like if I'm prescribing hydrocodone, that needs to come from me and only me. You can't get that from me and your surgeon and your primary care provider. Again, the multiple providers was a risk factor of unintentional death. So that is one place where we have identified one person prescribing, and it goes through one pharmacy. I know all this stuff seems so detailed and so unnecessary, but it really is. It does help cut down on inappropriate use. So again, contracts, drug testing, and follow-up visits every 3 months. And it's the patient's responsibility to take their medicines appropriately and keep them safe. I shouldn't have to be a policeman to make you take a dangerous medication the appropriate way. I shouldn't have to, double check that they're kept safe in your home so they're not stolen by grandkids. I mean, I've heard stories of people who are selling their house and like showing their house, and people came through and stole their narcotic medication. So, I guess this is what we've come to, but they have to be kept safe. I wanted to say something about the prescription drug monitoring programs. In case you saw news about this when our legislature was talking about it. We call it PDMP, I guess. It is just a database where everyone logs in and shows patients who are prescribed this medication and where they're getting it filled. So it would be patient XYZ prescribed by Carol Havlat and filled at Walgreens on 70th and whatever. And the reason to do that is so even an emergency room who doesn't know patients, they don't have access to that, they can log into that and see all of the places that the patient has gotten it from. Again, I wish this didn't that we didn't need this, but we have patients that hop around from doctor to doctor trying to get these medications, and then they keep it secret between all the pharmacies, and so that's going to go away effective January 2017. And Nebraska is actually one of the last states to do this, so I'm glad that bill passed. Talking about the contracts, why should we need one? And Safety of the patients, partly to educate them, partly so they know how to take it, partly for my safety. I always say that my goal is that none of the prescriptions I write will kill someone. And I mean, that sounds crazy that that's, what is associated with writing prescriptions. But it really is, even if my patients are taking it appropriately, if it gets stolen by a high school kid and something tragic happens there, that's why I'm such a stickler on this, because I look ahead and see what could possibly go wrong with this. Again, understanding who's responsible for what, and provides informed consent, meaning that they understand the seriousness of this and are willing to participate, to be a team member with me in doing these. And even if people didn't read it, they signed it, so we follow it. Things that we talk about in there, the risk benefits, like I went through, reinforces, they have to get their prescriptions from me and one pharmacy. If they want to change it to someone else, I will no longer prescribe it. And then we're going to talk about, drug screening and the follow-up appointments. It also outlines what someone would have to do that we would stop prescribing this medication in case the contract was broken. So it's all outlined very clearly. That doesn't mean that people aren't upset by it, but it is something that, we signed it, we're following it. So urine drug testing. We're going to talk about the details of this. And this is something new that our team is going to start doing because we have to for monitoring. There have been enough situations with abuse. So yeah, I thought that was funny. Okay, so these are the drugs that our current urine test will test for. I don't even know what all of those are actually, but anyway, just because someone tests positive for something doesn't mean that they're taking it illegally. I have a lot of patients on benzodiazepines. That doesn't mean that they're abusing them. It just means that they were prescribed them and that they're on them. And we get a full drug list beforehand and compare it. So I'll talk more about that. Sorry, this is kind of a long slide. So patient comes into the office. Obviously, we talk about that we're going to do this urine drug screening. We get a complete list of their medications and when they took them last. That's why it's very important for them to be honest. If I have a patient who says that they are taking hydrocodone and they took it that morning and then it doesn't show up in their urine, I don't believe them that they're taking it, and I'm worried that they're selling it. That happens a lot. Yeah, you have a question? Probably not, because we haven't actually started doing, I don't know if you see Dr. Valente or, oh, Dr. Churchill, yeah. Our team hasn't started doing this yet. Dr. Valente's has. So right now, no, that's just a normal urine analysis, but this is coming and we're going to make sure you know before we test it for that. We also have to know because, as I say down here, urine doesn't lie. The body doesn't lie. So we test the temperature and make sure that it's a normal temperature because people try and sneak in outside urine. People. You can't bring in pet's urine. You can't bring in someone else's urine. It has to be your own urine. We test the temperature. We go through all these steps. And so, yeah, urine doesn't lie. Don't try and get around the system because it doesn't really work very well. So anyway, we collect the urine with patients knowing and send it to Ameritox, who analyzes it and sends us a report back, tells us what the urine tested positive for, what drugs were in it, and then whether the amount was consistent with their prescribed dose, whether it was consistent with what they told us they were taking, and was there anything illegal or any illegal substances, marijuana, methamphetamine, things like that. Right now, our urine tests are going to be scheduled, that patients will know that we're doing them. My goal is to start doing them on patients once a year, just the way we check for tuberculosis and things like that, that if they're on these medications, that we'll just check this once a year and that will be part of it. But that we do that when we started treating it, any changes in it. If we saw some problems with functionality and we're maybe worried about the amount of medication that they were taking, and if the patient exhibits red flag behaviors, like being rude to the nurses, being very angry, being demanding, losing medications frequently, trying to push up their appointment to get more drugs, things like that. The random, I guess, yeah, yearly basis. And if there's red flag behaviors, yeah, we're going to start doing more testing for sure. Talking about the follow-up visits, these were the every 3-month ones. And I can do this as part of another visit. You know, if I'm talking about osteoporosis, osteoarthritis, and then we refill medications, that's no problem. Otherwise, if you usually only have to have every 6-month appointments, now you would just come in at that 3-month mark, and we would just do refills. This is the assessment that I have to do to fill out in the computer about what I'm looking for. I don't see any of this often, obviously, and if I do, is it necessarily because of opioid abuse? No. But, yeah, in the computer, that's what I have to put for an opioid visit.
Is this only for people with that
Absolutely. Absolutely. This is not for the general patient population. I don't know if there's anyone who's on oxycodone. There might be someone. So then maybe it would apply to, you know, any prescription opioids that are given in our office. And that is billed as a regular office visit. So you have a copay and things like that. Again, I'm sorry. Yeah, I have to do appointments every 3 months. That's not necessarily my choice, but hey, if it keeps people safe while taking these, then it's what we're going to do. So the dark story here, what if someone violates their contract? And I outlined some situations that would result in termination of a contract. Angry, demanding, disrespectful. I'm sure those of you who are here can't imagine being like that to the person who's prescribing your medications, but it does happen, and it happens more often than I am happy with. And I do not have to prescribe these medicines. I think that's something that I have to tell my patients sometimes, that I use them when they're appropriate, when we need them. I do not have to prescribe them, especially if I think it's a dangerous situation. Again, my goal is that no prescription that I write kills somebody. Sounds simple. So if I find out that another provider has prescribed it, if they're trying to keep pushing up their appointments, refill things before they're due. And that one, you know, if you're 3 days early, no problem. If you're 3 weeks early, consistently, that's a problem. If they refuse a urine drug test, that's a huge red flag. You know, if you would refuse to let us know what is in your urine. If it tests positive for illegal substances, that includes marijuana in Nebraska. So I have to tell patients, I'm like, I know you're using this recreationally, but if I find it in your urine, I will take away your hydrocodone. So think carefully if it's worth it. And if, like I said, if they say that they've been taking it and it doesn't show up. Now, all of these are very much on a case-by-case, situation-by-situation basis. We're going to get the full story, except for maybe the angry, demanding, rude one. That one we may not ask too many questions. So what we would do in that situation would be that we would no longer prescribe the opioids. We would obviously continue to manage osteoporosis or rheumatoid arthritis or things like that. We would just not be prescribing that particular medication. And they would receive a letter notifying them of what they had done, why we felt like it was not safe anymore to prescribe it, X, Y, Z. And probably I would send a copy of their opioid contract and highlight the part that was broken. And maybe would be given a 30-day supply of medication. Typically, we would taper down the amount of the medication. If you stop these medications immediately, like cold turkey, people usually don't feel very well, but we would give you enough to taper down off of. And usually after a couple of weeks, the withdrawal symptoms go away. So, and especially if you taper down. So obviously we're not going to just hang people out to dry here, but yeah, we'll have to stop it. So I made these last couple of slides that I feel like are very simple. So here are the things that you should do if you are prescribed these medications. Open communication, talk to us, tell us what's going on, if you think the medicine is working, if it's not working. Be an onboard part of the team. Managing pain is part of your job too. And be open to us saying we need to taper off of these medications because they're not doing any good. We need to use more physical therapy. We need to use more counseling. We have to treat your pain with the appropriate thing. Take the medications as ordered. Only use one provider. Keep a copy of your opioid contract. Cooperate with urine drug testing, and keep your medications safe at home. Flip side of this is what not to do. Here we go. Things not to do. Things that would result in stopping the opioid contract. Take more pills than your prescription is written for. I have patients who do this, and it frightens me. I had a lady who, she's like, well, it wasn't really working, so I took 2 the next time. And she was on a very high dose, and I was like, what? I was like, you are going to stop breathing. And she, of course, was like, what? These can cause what? And so I was like, okay, we need to backpedal and do a lot more education here. Can't lose your prescriptions or your meds. We cannot replace them. Obviously, accidents happen, things like that, but I can't tell if you're lying and selling it on the street, unfortunately. I don't know. Talked about scheduling appointments, sharing medications with others. That one's just not a good idea. As you saw on those couple of slides, we have warning, don't use with XYZ. We consider all of that when we prescribe the medication. Just, lending your hydrocodone to somebody else, it's kind of dangerous because you don't know how it's going to affect their other health conditions, things like that. Storing medications, obviously. Refuse drug testing, and go back to that being rude. Please don't be rude to us. It makes us not want to help you as much. So, to wrap up, if you only learned one thing, these are excellent safe drugs. We just have to use them safely. We have to use them correctly. As we talked about on those earlier slides, they are so common, they are so widespread, and I think that we're going to get smarter about their use as the next couple of years go on. We're going to get a little stricter about their use. We have to monitor these closely to protect ourselves legally, keep patients safe. Prince just died of a prescribed medication called fentanyl. So that kind of brought everything to the forefront for people that it was prescribed. It wasn't like he was getting that illegally. Again, urine doesn't lie. Don't bring in your dog's urine. We'll know it's your dog's urine. And gross. Don't be insulted if we ask you to sign a contract. We're doing it with everybody. If I ask you to do a contract and a drug test, it's not because I think you're abusing it. It's because I'm screening everybody. Good communication is key. That's medicine in general. And those are the references if you want to refer to them. And does anybody have any questions on it?